Pregnancy-related complications, Chapter 25. There are 3 common causes of hemorrhage during the first half of pregnancy, and they are abortion, ectopic pregnancy, and gestational trophoblastic disease. Abortion is a loss of pregnancy before it's viable, which is typically considered 20 weeks gestation. There are a few types of abortion. One is spontaneous, which means it happens on its own. Sometimes finding the cause of why they occurred can be very difficult. The most common cause is severe congenital anomalies. There are various types of spontaneous abortion, which include threatened, inevitable, incomplete, complete, or missed. The main symptom for abortion is vaginal bleeding. Treatment measure depends on if the uterine contents could be expelled completely. If not, dilatation and vacuum curettage, or D&C, may be required to remove the rest of the contents. Recurrent spontaneous abortion is 3 or more consecutive abortions. It's believed that these are genetic or chromosomal in effect. Nursing considerations include monitoring for excessive bleeding loss, which could cause hypovolemic shock. Another aspect is support to the family. It can be a very emotional time, and support is needed. Ectopic pregnancy is the implantation of a fertilized ovum in an area outside of the uterine cavity. More than 95% of these will occur in the fallopian tubes. Risk factors include history of STIs, normal or history of pelvic inflammatory disease, previous ectopic pregnancies, failed tubal ligation, IUDs, multiple induced abortions, maternal age over 35, cigarette smoking, and vaginal douching. Manifestations include early signs of a missed menstrual period, abdominal and pelvic pain, vaginal spotting, or light bleeding, and they may have a positive urine pregnancy test. These can depend on where in the tube plantation has occurred and gestational age. Neck and shoulder pain that is worse on inspiration occurs for more than half of all women. They will have a transvaginal ultrasound to help diagnose, and they will check the HCG levels. If these levels are lower than anticipated for the gestational age, then it helps to confirm the ectopic pregnancy. Remember, the HCG is a hormone level that rises with pregnancy. The normal levels correlate with the weeks of gestation, so if the levels are lower than what they should be at that point, then they think it could be ectopic. Therapeutic management depends on if the tube is intact or has ruptured. They want to keep the tube from rupturing to help with future fertility and less risk to mom. They can give the drug methotrexate, which will inhibit cell reproduction, so basically stops the process of any growth. Sometimes they will go in and surgically remove the products of conception. If the tube bursts, then risk for bleeding is increased and also the risk for infection. Nursing considerations will include monitoring for those. Providing support during this time is needed as well. Hydatidiform mole is a gestational trophoblastic disease and also known as molar pregnancy. This is an abnormally formed cells in the fertilization process where the placenta will form but not the fetus. It's characterized by proliferation and edema of chorionic villi. The fluid-filled villi form grape-like vesicles that can grow large enough to fill the uterus to the size of an advanced pregnancy if not diagnosed and treated. See Figure 25.3 for a picture. The mole can be complete with no fetus present or partial in which fetal tissue or membranes are present. Life-threatening complications can occur if not diagnosed. Acute respiratory distress may occur if the vesicles of the hydatidiform mole enter the woman's circulation and embolize in her lungs. Most are diagnosed with an early ultrasound that shows the vesicles and no fetus. Levels of HCG become high because of the rapid proliferating villi. Other signs could include vaginal bleeding, a uterus larger than expected, excessive nausea and vomiting, and early development of preeclampsia. Therapeutic management includes evacuation of the mole and follow-up to detect any malignant changes in the remaining trophoblastic cells. They will do chest images and labs to get baseline metabolic function, HCG levels, and clotting factors. Vacuum aspiration is usually the treatment measure used. After aspiration, Pitocin is usually given to cause the uterus to contract to avoid a postpartum hemorrhage. Curettage will often follow as the aspiration to be sure all remaining molar tissues have been removed. Follow-up is crucial. They will monitor HCG levels to help determine all cells are evacuated. Pregnancy must be avoided due to the risk of choriocarcinoma, which can occur. If malignant cells remain, chemotherapy course is taken. Nursing considerations include support. Anxiety can be high during this time for the family, so helping with coping techniques, referral to support groups, and therapeutic communication can help during this time. Placenta previa is the implantation of the placenta in the lower uterus near the fetal presenting part. They're classified as marginal, which can also be called low-lying, in which the placenta is implanted in the lower third of the uterus, but its lower border is less than 3 centimeters from the internal cervical os. The os is the opening. The partial, where the lower border of the placenta is within 3 centimeters of the internal cervical os, but does not completely cover it, and the total previa, where the placenta completely covers the internal cervical os. Marginal placenta previa can be commonly detected in early ultrasound, but as gestation progresses, it appears to migrate up further in the uterus. The classic signs of any placenta previa is a sudden onset of painless bleeding in the latter half of pregnancy, but many times it's diagnosed on ultrasound before the bleeding has begun. When a patient has a known placenta previa or presents to the OB unit with sudden onset of painless bleeding, verification of placenta placement via ultrasound needs to be done before any cervical exams occur. Therapeutic management includes considering the amount of hemorrhaging, results of the status of the fetus by the external fetal monitor. They also will consider gestational age. Depending on those results will determine the treatment measure. If mom or fetus is not stable, they will look at doing a C-section to deliver the infant. If time allows and the infant is less than 35 weeks, they may try to monitor for 24 hours so they can give mom betamethasone to help with the surfactant production to decrease the risk for respiratory distress in the fetus. If they both are stable, then sometimes treatment measures can be done at home. The criteria for this is there's no active bleeding, mom and fetus are stable, mom is able to remain on bed rest at home, they don't live too far from the hospital, and emergency transportation at all times if needed. Home care nurses can go to the home to monitor. Inpatient care will occur if other criteria is not met for home care. They will be required for fetal monitoring. And they also will monitor for increased bleeding, and they will watch for rupture of membrane. Abruptio placentae is a separation of a normally implanted placenta before the fetus is born. This can occur when there's bleeding and formation of a hematoma on the maternal side of the placenta. As the clot expands, further separation occurs. The severity of the complication depends on the amount of the bleeding and the size of the hematoma. The major danger to mom is hemorrhage and consequently hypovolemic shock and clotting abnormalities. Dangers for the fetus include anoxia, blood loss, and preterm birth. Maternal use of cocaine, which causes vasoconstriction, as a leading cause of abruption. Manifestations include vaginal bleeding, abdominal low back pain, uterine irritability with frequent low contractions, high uterine resting tone, and uterine tenderness that can be localized to the site of abruption. Other signs can include back pain, non-reassuring fetal heart rate, signs of hypovolemic shock, and fetal death. Hemorrhage can be concealed or apparent. In concealed, the bleeding occurs behind the placenta and remains intact. The amniotic fluid can have port wine appearance to it. The abdomen can become very firm or board-like. Therapeutic management includes being hospitalized, and maternal and fetal assessments need to be completed. If no signs of fetal distress and mom is stable and the fetus is not full term, they may just keep her in the hospital and monitor. They would give her a tocolytic medication to keep the uterus relaxed. If mom or fetus is not stable, preparation for immediate delivery is needed. 1 or more 18-gauge IVs should be in place, and mom should be monitored for signs of hypovolemic shock. Nursing considerations include support to mom and family. Continuous monitoring of mom and the fetus is needed. Hyperemesis gravidarum is a persistent, uncontrolled vomiting that begins in the first weeks of pregnancies and may continue throughout pregnancy. It's associated with the loss of 5% or more pre-pregnancy weight, dehydration, acidosis, elevated blood and urine ketones, and hypokalemia. The etiology is unknown. Therapeutic management includes ruling out other causes such as cholecystitis or peptic ulcer disease. Imbalance of electrolytes can occur, so many times the treatment is at home where the attempts to control the nausea are trialed. Vitamin B6 can help, as well as ginger. Antiemetics may be prescribed. If these measures are not working, IV fluid and electrolyte replacement may be needed. In some cases, TPN will be initiated to help with the nutritional balance. Nursing considerations include monitoring of I's and O's, watching for signs of dehydration, daily weights should be obtained, and monitoring for urine ketones. Collaboration with the provider to get a dietitian consult to help with dietary needs. When trying to reduce nausea and vomiting, be sure food is taken in small amounts and ones that are easily digested. Provide emotional support as well during this time. RH incompatibility can only happen when pregnant mom is RH negative and the fetus is RH positive. People who are RH positive have the RH antigen on their red blood cells, whereas people who are RH negative do not. When the blood from a person who is RH positive enters the bloodstream of a person who is RH negative, the body reacts as it would to any foreign substance. It develops antibodies to destroy the invading antigen. The entire red blood cell will be destroyed. In most cases, the maternal and fetal blood do not mix, but in circumstances of placental injury, can allow a small mixing of blood where the antibodies are formed and destroy the RH positive blood cells. This is known as isioimmunization. Sensation can also occur during a spontaneous or elective abortion or during antepartum procedures such as amniocentesis or chorionic villus sampling. Most exposure to the fetal blood occurs during the third stage of labor. Typically, the firstborn Rh-positive fetus is not affected, but other Rh-positive fetuses can be affected. A Rh mom will receive a dose of RhoGAM at 28 weeks, no matter what, and then if the infant is Rh positive, then the mom will receive another dose of RhoGAM before discharge. Implications to the fetus and neonate occur if the antibodies to that Rh factor are present in the mother's blood and they now cross the placental barrier and destroy the Rh positive fetal blood cells. The fetus then doesn't have enough RBCs, which you know are needed for oxygen transportation. When this destruction happens, fetal bilirubin levels increase, which can lead to bilirubin encephalopathy or kernicterus. This whole hemolytic process can cause rapid production of immature RBCs known as erythroblasts, which are incapable of carrying oxygen. This is known as erythroblastis fetalis. And the fetus becomes very anemic and will develop generalized edema, which can cause fetal congestive heart failure. Prenatal assessment includes a blood draw to mom to determine blood type and Rh factor. An Rh-negative woman will have the antibody titer known as the indirect Coombs test, which can tell if she has been sensitized. This can help determine if the fetus is at risk for developing hemolytic disease of the newborn. Like stated earlier, the Rh-negative mom will receive that RhoGAM at 28 weeks. A positive direct Coombs test indicates maternal sensation and the presence of antibodies against Rh-positive erythrocytes. It will be repeated during pregnancy to monitor if the titer is rising. Postpartum management includes the infant's blood type, and if Rh-positive, mom will receive that next dose of RhoGAM before discharge. ABO incompatibility can occur when mom's blood type is O and the fetus is AB, and so because blood type A and B and AB contain a protein component known as an antigen that is not present in type O blood. When this is present, babies can have anything from uncomplicated hyperbilirubinemia to more severe anemia. People with this type of blood type develop anti-A or anti-B antibodies from certain foods they eat or bacteria they are exposed to. As a result, some women can have high amounts of anti-A or anti-B titers before pregnancy. The antibodies or immune globulins can be IgG or IgM. The IgG antibodies can cross the placenta barrier and then cause a hemolysis of the fetal RBCs. This can affect the first fetus, but is less severe than Rh incompatibility. No specific prenatal care is needed, but the nurse must be aware of the possible ABO incompatibility. This baby would be at increased risk for hyperbilirubinemia.